started. Good afternoon, morning, evening, and welcome to this organized session on economics of HIV self-testing. We have three main presentations and one discussion. I will be introducing the presenters as we go along. To introduce myself, my name is Linda Sande. I'm with the London School of Hygiene and Tropical Medicine and the Malawi Liverpool Wellcome Trust. Our first presentation will be talking about the overview of the HIV self-testing Africa Research Program, and this will be done by Dr. Valentina. Valentina is an epidemiologist and infectious disease modeler working on HIV in sub-Saharan Africa and the UK. She's an associate professor in the Institute for Global Health at the University College London and currently holds a UKRI Future Leaders Fellowship. Her research focuses on HIV testing and prevention interventions in Zimbabwe and the UK, and she spends most of her time modeling HIV epidemics using an individual-based model for HIV transmission, progression, and the effect of antiretroviral therapy to investigate the impact of improvements in testing and prevention. Feel free to use the chat for questions, but we'll have a Q&A at the end, towards the end of the session after the discussion. Valentina, please go ahead. Thank you.
So hello everyone. So I'm just going to give a brief overview of what HIV self-testing is and what is the HIV self-testing Africa project. And then you will, during this session, you will have a flavor of what is the economic research that is being conducted as part of this project. Having declined by 30% since 2010. The AIDS epidemic is not over, with 1.5 million people newly infected with HIV in 2020. And the burden of HIV remains in sub-Saharan Africa, where 58% of HIV infections occur. So expanding access to HIV testing services and linkage to prevention and timely antiretroviral therapy is vital to achieve epidemic control. Next. So since 2000, in Africa, there has been a dramatic increase in the proportion of people living with HIV who are aware of the HIV status. And as you can see, for example, in Southern Africa, this has increased from around 10% in 2000 up to around 90% in 2020. But as you can appreciate, there are disparities by region, gender, and age, with really Western and Central Africa, men and young people lagging behind. Next. So as the proportion ever tested with HIV and consequently the proportion aware of their HIV status increases, you can see that the HIV testing positivity rate declines. And as the positivity rate declines, then not surprisingly, the cost effectiveness of HIV testing modalities generally falls. It's becoming more and more challenging to find HIV testing modalities that are cost effective and at the same time contribute significantly to achieve the UNAIDS target of 95% of people living with HIV being aware of their status. So next, so HIV programs are seeking novel ways to really close this gap. HIV self-testing, next, has the potential to offer such an opportunity. It is the process by which a person who wishes to know their status performs an HIV test themselves and interpret the result in privacy. And this can be either using an oral fluid, so a mouth swab test, or a finger test on whole blood. Next. So several distribution models of HIV self-testing have been proposed, and some of these have been evaluated in STAR. So next. The STAR project really represents the world's largest evaluation of HIV self-testing today. It distributed over 4.8 million HIV self-testing kits. It supported development of HIV self-testing policy in 80 countries and actively implemented HIV self-testing in 38, and actually directly supported national government in the development of HIV self-testing in 13 countries. As part of STAR, the research took place in kind of three phases. The first one from 2015 and 2018 is next is fine. where HIV self-testing were evaluated in different testing modalities. And this took place in Malawi, Zambia, and Zimbabwe. And the second phase, phase 2, refers to the STAR initiative, took place between 2018 and 2021. And it took place in 3 additional countries: South Africa, Lesotho, and Eswatini. So as you can see, a lot of economic research took place as part of the STAR project. Costing studies were conducted in all 6 countries, scale-up cost modeling in 5 of them, and cost-effectiveness modeling in 3, and similar discrete choice experiment to better understand preferences in 3 of them. And as you can see, several HIV self-testing distribution models were evaluated in economic research. And you get a flavor of all this research in this session. Thank you.
Thank you, Valentina. Our next presenter is Ms. Kathleen McGee, who is a health economist with over 9 years of international research experience, providing technical assistance and guidance in health policy, planning, and strategic resource allocation. She has an MSc from the London School of Hygiene and Tropical Medicine in health policy, planning, and finance. She recently worked with STAR, conducting a top-down costing study and supporting a systematic review on the cost of HIV testing in sub-Saharan Africa. She's currently consulting with UNAIDS, critically reviewing countries' costing of their national HIV programs. Please go ahead, Kat. Thank you.
Good morning and good afternoon, everybody. So my name is Kathleen McGee, and I'm excited today to be presenting results from 2 STAR economic evaluations conducted in South Africa and Eswatini. Both studies evaluate the costs and the outcomes of HIV self-test kit distribution along the HIV care cascade. So before starting, I'd like to thank both studies' co-authors, the STAR team, and the country teams that conducted distribution. Next. A little bit of background next. So we have 2 completely different countries with very different epidemiological contexts. On one hand, we have Eswatini, a small landlocked country that suffers with the burden of having the greatest HIV prevalence in the world, with an estimated 27% prevalence rate. So this translates to about 211,000 people living with HIV. And according to Spectrum estimates, there was about 6,400 new HIV infections expected in 2020. Conversely, South Africa has the greatest burden of HIV infections in the world. The prevalence rate is about 13%, with a very large population. This translates to about 7.8 million people living with HIV. And in 2018-2019, 201,000 new infections were estimated to have occurred. So in regards to the UNAIDS cascades targets, in Eswatini, it's now believed that about 98% of people living with HIV know their status, of whom 96% are in treatment and 92% of whom are virally suppressed. And comparatively, South Africa's estimates are 92, 70, and 64% respectively. Next slide. So both studies in Eswatini and South Africa share similar objectives and purposes. First, it's to contribute further evidence regarding the health outcomes and impact of HIV self-testing distribution. Secondly, it's to contribute evidence regarding the costs of HIV self-testing distribution. We also wanted to compare costs between different types of distribution models, including community, workplace, and facility distribution. And finally, we wanted to fill a significant gap in the literature today regarding the average cost of HIV self-testing distribution along the client care cascade. So in fact, to date, most HIV self-testing studies have been restricted to only reporting the costs per kit distributed. And in these 2 studies, we sought to also evaluate the average cost per client self-tested, the cost per client self-tested reactive, the cost per client confirmed positive, and the cost per client initiating ART. Next slide. So in regards to methods, both studies shared strong similarities, but there were some differences. So in Eswatini, the study compared distribution costs between the community and the workplace model, whereas in South Africa, the study was much more extensive, looking at 3 models, including the community, the workplace, and facility model. as well as 11 submodels that fall under those. In Eswatini, regardless of the distribution method, clients could choose to test either on-site or off-site, whereas the on-site option was only available in the mobile submodel distribution in South Africa. And in both countries, clients could take self-tests either for primary or secondary distribution, meaning they could take a kit or several of them to use themselves or to pass on to a friend, a partner, or someone of their choosing. In both countries, we monitored, of course, kit distribution, as well as on-site testing uptake and the results of those tests. For off-site testing, both studies conducted telephonic follow-up with a subset of clients. And in these phone calls, clients were asked whether they had used their test, the result of their test, whether they had sought confirmatory testing at a health facility, and if positive, if they had initiated ART. And from each of these measured health outcomes, we then estimated the average costs along the care cascade. Next slide. So in regards to the costing methods, both studies evaluated costs over the span of 1 year of implementation from a provider perspective. The Eswatini study conducted a top-down cost evaluation of the full cost of implementation, but didn't include startup phase of the project, nor included research costs. The South Africa combined top-down and micro-costing using a time and motion approach to estimating in both full and economic costs. The study excludes research costs, and capital costs were annualized in both studies and a 3% discount rate applied. Finally, costs were allocated to each model according to the number of kits and the staff time attributed to each distribution model. Next and next. All right, so a total of 19,000 kits were distributed overall in Eswatini, and over 1 million kits were distributed in South Africa. The majority of kits were distributed through the community model in both countries, followed by the workplace model, and finally the facility model in South Africa. Overall, 15% of clients in the Eswatini study were contacted, of whom 74% were successfully reached and interviewed. And in South Africa, follow-up rates differed according to the distribution model, but overall 5% of total clients were contacted, of whom 78% were successfully reached. Next. So this is the same information as was provided in the table in the slide before, but in the cascade chart format. And the first thing to note, of course, is the significant difference in the yield according to country and distribution model. The second important takeaway is the very wide differences in the estimated linkage to care rates. The percentage of people presenting for confirmatory testing range between 50% to 96%, and the percentage of persons tested positive initiating ART range between 18% to 83%. Next slide. So of course, the cost per unit increases along the care cascade, and the cost per kit range between $6 to $17. The cost per client self-testing reactive ranges between $139 to $527, and the cost per client confirmed positive ranges between $247 to $556. Finally, the cost per client initiating ART ranges between $311 to $801. Next and next. So what are the key points that emerge from this evidence? So starting at the beginning of this cascade, what we notice, of course, is that there's a pretty wide range in the average cost per kit distributed, and it goes from $4.30 in South Africa up to $17.23 in Eswatini. And that range is strongly affected by the number of tests distributed. Indeed, the more kits we distribute, the lower the costs. And of course, volume of kits distributed is driven by local demand and the need for kits. So the greater the client population, the lower the average cost per kit distributed is likely to be. So the average cost per kit distribution demonstrates an economies of scale. Next. Can you go next? And we'll come back to limitations. right? And in regards to the average costs along the subsequent steps of the cascade, countries with declining testing yields, such as Eswatini, where 98% of people living with HIV are estimated to know their status. So in countries with declining testing yields, they will experience greater average costs along the client care cascade. The last conclusion we can make is that linkage to care rates are tremendously important, not only to a country's successful achievement to its HIV targets, but also to ensure cost effectiveness and distribution optimization of HIV self-testing. So that's it for me, Linda.
Thank you, Kat. Our next presenter is Dr. Mark de Elbe, who is presenting on scale-up modeling of HIV self-testing. Mark is a health economist working on HIV prevention programs in sub-Saharan Africa. He's a research fellow at the London School of Hygiene and Tropical Medicine. He has previously worked on conducting discrete choice experiment, costing and scale-up cost modeling studies. He is currently doing a part-time PhD on methods for projecting healthcare costs at scale in LMIC with the STAR and ATLAS research projects implementing HIV self-testing in Southern and Western Africa. Mark, please go ahead.
So thank you, Linda, for the presentation. Well, hello and welcome, everyone. So my name is Mark Delbé. I'll be presenting today a case study of scaling up community-based HIV self-testing programs in Lesotho to further explore methods used in LMIC to project healthcare costs at scale. Next, please. So in terms of background, so as we have seen, community-based models delivering HIV self-testing either at people's home or within the community setting were shown to be a convenient approach for reaching under-tested groups such as men and young people. And following the success demonstrating in the STAR initiative, the Lesotho MOH added HIV self-testing to its revised national HIV testing strategy for 2018-2023. And an analysis of the cost of scaling up HIV self-testing was indeed by country planners to inform national scale-up plans in Lesotho. Cost functions can be derived from a production function to estimate the total cost of production given a specific output produced. Econometric cost functions do not follow the production process, but rather apply statistical inference to predict cost. Next, please. So this study aims to fit an econometric cost function to estimate the cost drivers of community-based HIV self-testing programs in Southern Africa using data from Malawi, Zambia, Zimbabwe, and South Africa. We then inform the use of cost functions to predict costs at scale by comparing different cost function models with different level of data requirements. And finally, we assessed validity of this empirical cost function by comparing projected costs with observed costs at scale in Lesotho. And we selected Lesotho as our case study because we conducted in this country a microcosting longitudinal analysis of HIV-ST scale-up over 2 years of implementation. So in terms of methods, so cost data were collected between June 2016 and June 2019 across all countries. The analysis of observed costs at scale in Lesotho we're using cost collecting between August 2017 and April 2019, where we identified 3 different scale-up phases of approximately 6 months each. We estimated the economic cost of community-based HIV-ST distribution programs in 92 sites across Malawi, Zambia, Zimbabwe, South Africa, and Lesotho. Program expenditures were supplemented by on-site observation and M&E data, and were used to estimate distribution costs. In some countries, we also conducted some time and motion studies. Finally, costs were adjusted for inflation using each country's consumer price index and presented in 2019 US dollars. Next, please. So we use here a linear regression approach with ordinary least squares and used average cost per kit distributed as the dependent variable. Because the cost data were highly skewed to the right with a heavy tail, we log transform the dependent variable. The selection of cost determinants was based on the economic theory of production function through program observation and the literature on cost functions for HIV care services. We also used likelihood ratio tests comparing the goodness of fit of two statistical models to assess whether or not we could simplify a model. And when we say simplify, we mean reduce the number of parameters in our regression model for cost projections. Next, please. So I'm only presenting here a few descriptive statistics. So the sample mean of average cost per kit distributed across sites was around $15. On average, each site had 26 distributors and distributed 1,300 kits. Part of the strategy was to reach men and those who had never tested for HIV before, were never tested before, yes. And this group made up on average 48% and 12% of kit recipients. Next, please. So in this table, we present some of the model output. In model 5, we present all cost determinants, followed by model 6 and 7 for our simplification approach. The key takeaway messages here are that major cost determinants were scale of HIV/ST distribution, the type of community-based intervention, in particular campaign style, the percentage of kit that were distributed to men, the distance from the implementer's warehouse, and the price level as proxied by the per capita GDP. We found a negative association between scale and average cost and a positive association for the other drivers. For the model simplification analysis, we removed insignificant variables, such as the percentage of those who never tested for HIV before, the positivity rate, the costs of conventional HIV testing at nearby health facility in the sites, and an efficiency variable in model 7. And removing these variables did not significantly reduce the goodness of fit of our model, as shown by the insignificant likelihood ratio tests. Next slide, please. So here we present observed total cost for each scale-up period at national and district level in Lesotho against the projected costs from models 5 to 7. Overall cost projections at given scale were close to observed costs at district level and the national level in period 1 and 2 observed in Lesotho, whereas we report some discrepancies at national level in period 3. So we'll come back to that. The comparison of projected costs also showed that more parsimonious models like model 7 were not less accurate than more data-hungry models, as was expected based on the results from the statistical analysis. Next, please. So a few discussion points. So first of all, our results suggest that program design characteristics, including the scale of HIV/ST distribution, the type of community-based intervention, the characteristics of the targeted population, in particular men, reaching men, the distance from the implementer's headquarters and the per capita GDP could be used as data to predict average cost. The model simplification approach also suggested that we could use a more parsimonious model to predict cost without significantly losing accuracy, which is making sense from a statistical point of view, but which is particularly relevant in our context, as in most studies, we would often have kind of opportunities to collect large amounts of location-specific cost data, or that the necessary background information might not exist. The per capita GDP variable also showed that this cost function could potentially be applied to other countries in the region. However, it would probably require additional or different variables in other settings, such as in West Africa, for example. Next, please. Okay, so there were a few limitations, maybe they appeared.
Mark, you have less than a minute.
Okay, so I'll just conclude then. Our empirical analysis adds to the discussion on the trade-off between simplicity and accuracy in cost projection methods. In terms of further research, should estimate healthcare intervention costs at scale using alternative cost function method and compare cost predictions at various scale in order to inform the choice of a cost prediction method based on the intended use of these cost estimates. And you can also find further information with this publication. So thank you very much all for your attention.
Thank you very much, Mark. And just to say you do not go over 8 minutes. That's great. Thank you. Our final presentation will be coming from Valentina, who I already introduced. So Valentina, please go ahead.
Yeah, so hi everyone again. It's really my pleasure to present this work, which has been a very kind of collaborative work on the cost effectiveness of HIV self-testing in Southern Africa. Next. So the aim of this project was really to compare the cost effectiveness analysis of different adult HIV self-testing distribution modalities conducted under the STAR project. And you can see of the modalities of distribution that's been summarized by the World Health Organization, 4 of these kind of broad categories were evaluated in the STAR project. Next. So 3 models took part in this comparison. The Thembisa model, which is a compartmental transmission model simulating the entire population of South Africa and calibrated to the epidemic in this context. And this work was led by Liz Jamison, Gesine Meyer-Rath, and Lee Johnson. Then we have a second model, which is a non-transmission Markov microsimulation model, which simulated the population not testing in the last 12 months and living with HIV not diagnosed. And this was based on the fact that this was the population eligible to receive an HIV self-testing in the context of Zambia. And this work was led by Nuri Ahmed, Fern Terry Presshold, and Jason Ong. And then for the synthesis model, this is an individual-based transmission model simulating the entire population age 15 and above and simulating a range of HIV epidemic in Southern Africa. Next. So all the models evaluated the cost effectiveness of community-based approaches, different ones. And the Thembisa model and the synthesis model consider partner-delivered models, also referred as secondary distribution. Both of them consider secondary distribution to partners of pregnant women attending antenatal clinics. And then the Thembisa model considers distribution to partners of patients attending clinic for antiretroviral therapy. And the synthesis model considers distribution to partners of female sex workers. And then the Thembisa model considers as well primary distribution in primary health clinics and distribution in workplace. Next. So the way in which kind of HIV testing can produce health benefits is really 2 ways. The first one in people without HIV is through the fact that HIV testing really represents the gateway to access voluntary medical male circumcision, which reduces the chance of acquiring HIV in men by half. And the chance of accessing pre-exposure prophylaxis, which is highly effective, but needs to be taken in order to provide protection. So through this route, HIV infections can be averted. HIV testing can produce a benefit among people who live with HIV, as in order to access antiretroviral treatment, people need to be diagnosed with HIV. And then antiretroviral treatment produce health benefit in these individuals in terms of a decrease in morbidity and mortality, but as well due to the fact that people who are virally suppressed on antiretroviral treatment do not transmit the virus to others. So secondary kind of infections can be averted, and this effect was captured by the Thembisa and the synthesis model. Next. So just to give kind of a quick reminder of the fact that these 3 models consider different settings. Click. And for example, the HIV incidence was different in these 3 settings, and the proportion diagnosed, so aware of their HIV status, was different. For example, in South Africa, this was a lot higher, as Kat has already shown, above 90%. And so we would expect that in this setting, it is more difficult for HIV testing modality to be cost effective. Next. So all 3 models assumed a very high specificity, both of the HIV self-test and of HIV testing services. So those conducted by kind of like trained individuals, and a lower sensitivity, especially for HIV self-testing. Next. As mentioned, in order for HIV self-testing to kind of translate into health benefit, people need to have a confirmatory test in order to be diagnosed with HIV, and then they need to be linked to care and in order to be able to initiate treatment. And as you can see, there were disparities in this assumption due to the fact that there are disparities in linkage to care in the different settings. Next. As you can see, in terms of duration of the intervention, the Markov model evaluated the cost effectiveness of HIV self-testing being introduced for 1 year, while the Temvisa model and the synthesis model considered the cost effectiveness of this intervention being introduced for the kind of full time frame. The Temvisa model evaluated distributing a target of 6 million HIV self-tests using one single distribution channel, compared to a status quo where a combination of HIV self-testing distribution are used, while both the Markov model and the synthesis model compared to HIV self-testing not being introduced. Next. They all used a healthcare provider perspective. They all used a long time horizon. The Markov model and the synthesis model express the incremental cost effectiveness ratio in terms of cost per DALI averted, while the Temvisa model expressed in terms of cost per life year saved and cost per HIV infections averted. The Markov model used as a cost effectiveness threshold the 1 GDP per capita in Zambia, and the synthesis model considered a lower threshold. Next. In terms of costs that were inputted into this model, you can see that in the Temvisa models, these costs were based from estimated in South Africa, and they were around $5–6 for the taxi rank and the fixed point distribution, the average cost per test distributed, followed by the cost of campaign style approach, and this estimate come from Zimbabwe around $10, and then the door-to-door distribution from Zambia at $14. Next. In terms of costs of partner delivered and the other modalities, you can see that the secondary distribution, both to partners of pregnant women attending antenatal clinic and to people attending the clinics for antiretroviral therapy, were around $13. The secondary distribution to partners of pregnant women attending antenatal clinic was lower in Malawi at $8, and at $5 for secondary distribution to partners of female sex worker. And the cost in the context of South Africa was at around $8 for primary distribution in primary health clinics and around $5.6 in workplaces. Next. So what are our findings? And I'm really kind of here trying to summarize what the 3 different models are finding. So if we focus first on the bubbles in green, these are community-based modalities. You can see that in the Temvisa model, both the taxi rank and the fixed point distribution were the next cost-effective option after the workplace in red, with around between 2,000 and 2,600 cost per life year saved. In the Markov model, they look at door-to-door distribution in different age and gender group. All these distribution models were found to be cost effective, but actually the health benefit was greater when targeting older group. And in the synthesis model, both campaign style distribution to young people and to adult men was not cost effective at this level of prevalence of undiagnosed HIV, but it was cost effective when targeting female sex workers. Next. When looking at partner delivery modalities, so we are now looking at the bubble in purple for secondary distribution to partners of women attending antenatal clinic. You can see that this was not cost effective neither in the Temvisa model or the synthesis model, and the health benefit was quite limited. But if we look at the secondary distribution to partner attending clinics for antiretroviral therapy, so that bubble in light blue in the Temvisa model, you can see that this was the least cost effective option, but actually it was producing the greater health benefit. And if we look at the secondary distribution to partners of female sex workers in orange in the synthesis model, this was a cost effective approach. Next. So the Temvisa model, as mentioned, considered as well 2 other approaches, which are the primary distribution in primary health clinics, the bubble in yellow. You can see that this distribution modalities was cost saving, but was actually producing a decrement in health benefit. While the workplace distribution was the most cost-effective option in the context of South Africa, it was producing health benefit and was cost saving. So next. So, and I apologize in advance because I really haven't had the time to dig in all these conclusions. So feel free to ask questions. There are HIV self-testing distribution modalities that are cost-effective. Workplace distribution in South Africa is even cost-saving. The main factors that were found kind of across the model influencing cost-effectiveness are the prevalence of undiagnosed HIV, the size and the risk of HIV in the subpopulation receiving HIV self-test, linkage to treatment or prevention following the HIV self-test. And just to know that so far, the models haven't really explored in depth linkage to prevention following the HIV self-test, as there is not a lot of evidence, for example, of linkage to pre-exposure prophylaxis. The duration of the intervention, as you saw in the Zambia models, the intervention were more cost-effective as they consider only 1 year of the duration of intervention, and the cost, of course, the cost of the HIV self-test distribution itself. And finally, I would like to thank you for your attention, and really, I want to acknowledge the co-author, especially Nouri Gerzin and Liz Jamison, who really helped me put together this presentation. Thank you.
Thank you very much, Valentina, and all our presenters. Now we'll have a discussion by Dr. Tato Shidarikide, who will be sharing her screen. As an introduction, Tato is the Director of HIV Prevention Programs in the National Department of Health in South Africa. Her portfolio includes management of HIV prevention programs, including but not limited to HIV testing, pre-exposure prophylaxis, post-exposure prophylaxis, condoms, STI management, communication, and stakeholder management. She has over 20 years professional experience gained in academia, public health sector, and research units and parastatals. With 17 years in the HIV field, her vast experience includes policy and guideline development, HIV prevention intervention programs, research, and clinical trials. She has co-chaired the WHO HTS Guideline Development Group, the National PFIP Prevention Work Stream, and the National HIV Think Tank. She is also a PhD graduate from Wits University with a specialty in biology. When you're ready, Tato, please. Thank you.
Good afternoon, everyone. I'm Tato Shidarikide. It's already been introduced. I don't know if you're able to see me on the video, but I think maybe to preserve my bandwidth, I will stop it so that I can actually manage with the Wi-Fi. So I'm going to be talking to policy and practical application from a policymaker point of view. And I'm glad that really with all the other presentations and the presenters, we're all kind of like working towards the same goal. We seem to be thinking in the same way. Trying to move my screen. Right, so really what informs policy? And as policymakers, we're really informed by data and research, and this has already been confirmed in the previous presentation. Cost-effectiveness is also very important in terms of value for money if one needs to actually focus for impact. And that talks to my next point, is the direction is really focusing for impact, then modeling has become very crucial to provide that guidance and for us in terms of focus. And we need to identify where to mobilize our resources, what should be scaled up, and at what magnitude. So what are the strategic outcomes of policies that we need to ensure that whatever it is that we want to implement or change will actually provide the impact that we are looking for. So now we know what we need. So what is it that will actually work? Clear evidence-based intervention has already been shown within this presentation. Studies, data, what works as per what, data and cost effectiveness, comparison of different modalities in terms of implementation, different populations, we all have different burdens in terms of populations, demography, geography, and we need to ensure that we have clear targets, especially looking at impact at a very granularized manner based on geography and population that will ensure that our data and cost effectiveness comes out very clear. and that will also inform our targets. Moving forward, we actually have also, maybe it's good to mention that it's also very important to note that, as countries have, or some are chasing, some have reached their first 90, and we are now moving towards the 95, and our first 95 in terms of HIV testing services. It's very important to note that we may not necessarily be looking at, for lack of a better phrase, low-hanging fruit. We may actually be looking at the high-hanging fruit, and we may not necessarily be looking at cost effectiveness in that literal manner while we are looking or chasing the last mile for targets. We look at HIV testing. In South Africa, for example, HIV testing services have been run for many years on the backbone of public health facilities, but we've opened up now to communities, to workplace, and we are also at self-testing, which, as you know, we refer to as self-screening. But even there, with all the support that we received, in the last 2 years, communicate to the STAR, in the STAR initiative, like most countries, it was very important that as we adopt and adapt and develop our policies, we look at scaling up now, because the STAR has catalyzed and we now need to scale up. And for us to do that effectively, we looked at our modeling and what works in terms of the different modalities. So this is just a little bit of background in terms of South Africa testing. I've talked to it, most of it actually. If you look at the graph, we'll see that from 2002, we started at just about 2 million tests performed, and through to 2015, we were now looking at about 12 million, and up to now in 2019, we're having a target of 14 million tests per annum. And throughout this, we are looking at different modalities that work, different modalities that are able to assist us with, reaching those undiagnosed or untested, undertested, percentage of those diagnosed that are actually still remaining low at this point. We have some concerns, in terms of testing strategies currently, and we are looking at what is the most efficient and cost-effective in terms of impact. And again, which modalities are most cost-effective, even though we know that we were actually chasing the last time. So having looked at the different modalities, having looked at different papers published, having looked at our modeling in teams in South Africa and the support there in terms of cost-effectiveness in different cases and data and support in general, we come to different considerations that we need to look at in order to inform our policies moving forward. So the questions then or considerations become how different HIV testing strategies can compare in terms of the percentage of people tested who are newly diagnosed, that testing gap that we are still trying to look at for those that are under-tested and untested, and those who may not necessarily go through traditional testing in some cases for different reasons. And again, cost is very important. Secondly, we need to consider HIV testing strategies that are most critical to reduce the fraction of those that are HIV positive in the population that are undiagnosed. And I believe that, in the 3 years that at least we have done or have dealt with or implemented different modalities on HIV self-testing or self-screening, we have come to a point where as a country, yes, we have taken self-testing in terms of domestic funding, we are implementing and trying to scale up, but it's still very important to work with our modelers and ensure that our policies are informed accordingly based on our data. And I think I'll pause here and just thank my colleagues, our modelers, I think in particular at this point, Gavin and Tim, Linda, just to basically acknowledge and say thank you for the support in this regard. Thank you.